more on the headache journal, because so many people ask me, well, I've never kept a journal, or I'm not good at keeping a journal. Some of the things that are really important for the physical therapy aspect of it is if they're getting them at the same types of days each time, how long they're lasting, what the intensity is, what symptoms they're getting with the headaches, if they did any type of activity prior to having the headache. So if they did a certain exercise that we prescribed and then they had a headache, we need to reevaluate that exercise. We need to make sure that they're doing it properly, that they're recruiting the right muscles, and they're not triggering something that could be making their headaches get worse. And if that's the case, we need to get rid of that exercise and try something different. So.
Amy, I just handed out a headache log.
Oh, perfect.
But I'll share it with you before you go.
Okay, great.
No hurry on that.
We also want to know if they have taken any medications prior or after, the amount of sleep that they got the night before, what their emotional condition was, the weather, foods, and then for women, menstrual cycle times. So after we've kind of gathered information and kind of talked about what's going on with them, we'll move into what we call the objective evaluation. And so that usually starts off with a posture assessment. For men, we usually have them remove their shirts. For women, we'll have them change into a gown with the gown open in the back. And so we're looking at a lot of different things here in their standing position. And I generally have to remind them, this is not your army posture, this is how you normally would stand. And so from the back, what I'm looking for is the shoulder blade position. Did you still have that pointer, Aaron?
The pointer is actually part of the...
That's okay. So you can see in this gentleman here, this is a pretty typical shoulder blade. And so you can see how this left one here is vertically up and down. We would rather see the top edge of the shoulder blade a little bit closer to the spine than the bottom edge. You can see on the right shoulder blade, the top edge is farther away from the spine than the bottom edge. You can also see how the insides kind of stick out a little bit. That's what we call winging shoulder blades, and so that's due from weakness in the serratus anterior muscle, so a muscle that helps stabilize the shoulders. You can also see from here, the bottom edge is what we call tipping. That's from a muscle on the front side of your shoulders, pulling the shoulders forward. So if you think about maybe someone who sits at a desk all day, or someone who drives a truck, or drives a delivery vehicle all day, if they are consumed to their keyboard or to their steering wheel, they're going to get in kind of a more hunched over position. And so that's pretty typical shoulder blade pattern there. We're also looking at their cervical position. Are they in that neutral spine? Are they tilted to the side? You can see here his muscle on the top on this side is a little bit different compared to the left side. So we're just looking for asymmetries, looking for different things that could tell us a little bit more about their daily activities and some things that we can change there. From the side view, I actually drew this red line through my laptop here. So again, we're looking at this neutral spine from the side. This posture assessment, I think, is probably more important and more practical than looking from the back. So from the side, there's what we call a plumb line, and that plumb line goes vertically through a few major body points. And so from the top, we have the ear, and then the shoulder, elbow, hip, knee, and ankle. When one of those body parts is in front or behind the line, that's when you can start to have musculoskeletal problems. And there's a horizontal line here between the nose and the ears, and that is also equally as important. A lot of times what we'll see is the nose is higher than the ears, therefore causing tightness in the suboccipital muscle group, which lies here behind the skull and can be a major factor in individuals with headaches. So we're also looking at trunk position, if they're leaning forward or back or rotated. We're also looking at this area here. I don't know if you have seen any individuals that may have osteoporosis or maybe in their later years that are kind of hunched over and have some excessive bump right here. That's something that we will look at and is very common in individuals with headaches. So this area here, the larger the bump generally means the less motion they have in that area. Most of the time it means that they're hinging or moving above that area. And so one of our goals with therapy is to improve the mobility and increase their overall motion throughout their spine. Okay, you can turn the lights back on. Okay. range of motion. Range of motion can definitely tell us where some muscles could be tight. It can tell us where they may be having pain. And so we'll look at active range of motion in addition to some passive range of motion. We'll look at shoulder blades, actual shoulder between the ball and socket area. We'll look at cervical rotation, cervical flexion and extension, in addition to forward head posture. There's been a high rate of forward head positioning that correlates with headaches. And so that's one of the newer things that I started doing after I started working here. We'll also look at their strength throughout their neck and shoulders. And a lot of times my patients will ask me, well, why are you looking at my shoulders? My shoulders don't hurt. Even if their headaches maybe radiate down into the neck, their shoulders still aren't hurting. And that's not true with everyone, but it still can. The best way that I can explain this is that your whole shoulder complex, its bony attachment, is right here through your sternum, through a very small piece here. So it heavily relies on muscle control. If that muscle control is out of balance, then that can throw off your whole shoulder complex. And because there's so many muscles that attach from the shoulder blade to the neck, it can also damage how your neck is moving. So it's kind of a chain reaction, neck to shoulders and shoulders to neck, back and forth. They can, play on each other reversibly in that aspect. So that's why we evaluate the shoulders and take that very seriously. Also look at reflexes, sensation, and then we'll do a manual assessment of the spinal movement. So from all of the range of motion that I have my patients do on their own, I will look at them as well passively. And that's usually the hardest part because patients don't want to just give their total head to me. They just want to hold it and move it themselves. And so I just have to say, relax, relax. I need to see what their joints can do rather than what their muscles can do. And lastly, one of the things that we'll check with all of our headache patients is a soft tissue assessment. And so as we're doing this, we're looking for muscle tightness, we're looking for any tender points that they may have, and any active referral patterns.